When you don't take time to look at it through other people's eyes. Take some time and reflect on what you believe in your soul. Cause that is the key to life. You gotta let the negativity go.
Hello, and welcome back to another episode of the What the Fox podcast with your hosts, Lindsay Fox and Amber Ross.
Hello, everyone. Today we have a lovely special guest, Rachel Hickey, meeting with us today to actually talk about eating disorders. And just as a reminder, for the month of May, it is Mental Health Awareness Month. So that is why we are choosing this topic, because as you will learn today, eating disorders actually are they profoundly impact our society and actually have a very high percentage of individuals, whenever you look at the full scope of mental health disorders, where people do pass away either by suicide or cardiac arrest. And we don't really talk about these things. So Rachel, welcome. We are glad to have you.
Much. Very happy
glad to have you. Yes, we're glad to have you. And just to clarify here, Rachel, you not only work in this profession as a licensed mental health counselor, but you also are an adjunct lecturer at a local university in Massachusetts. And can you tell us what you teach, by the way?
Yes, I teach psychology of women.
Wonderful. So what does that comprise of exactly? Because usually when we think about eating disorders, by the way, we think about women,
yes,
right?
We do. And that's how we've been socialized for sure. So I have a pretty broad array of topics in my curriculum. So I do feel a little bit bad for my students that I don't spend more time on each one, but I want to make sure that they have a really large variety of topics to go through. So anything from, adolescent development, mothering, violence against women. I naturally have a whole unit on eating disorders.
Good.
Work and achievement. So it really kind of runs the gamut of topics.
Yeah, so that's totally fine, but I think it's a very important topic to cover because frankly, I feel like even as clinicians in graduate school, we really don't learn much about eating disorders. So
That's true.
I mean, newsflash to those.
I didn't do graduate school, but that's something that needs to be brought into all curriculums at all stages because it's definitely
my recollection in grad school is we had, I think, one unit on eating disorders that they combined with addictive disorder.
Exactly.
Wow.
And it was just, they just kind of, you cram it all in together because to your point, what you're saying is you're divvying up your curriculum. So you're touching on, you said domestic violence, for instance, in this curriculum. So domestic violence is not something that we really talk about in grad school.
Exactly.
Because if you're going the route of clinical counseling, you're focusing more on technique. So it is, it's a little bit different in that sense, but I'm so glad that you're able to bring that to the place where you're working to help educate and inform. And I'm kind of wondering, Rachel, what got you interested in eating disorders in the first place? What kind of drew you to that topic?
Right. Well, to be completely honest, there were never anything I had heard of before. The first time I really was exposed to it, I was in junior high, and we had this brilliant teammate. She's just phenomenal on my basketball team, and she developed anorexia nervosa. And that was the first time I had ever come across that term even.
I mean, that's actually a pretty young age, by the way, to even hear that term, because I actually think a lot of people, you said junior high, so middle school, a lot of people haven't heard that term by that age. So for all intents and purposes, you're actually kind of young to learn that term.
Yeah. And part of me feels that it's avoided because, similar to when parents are avoidant to have discussions around suicide or depression, they have this misconception that if I talk about it, then they're going to do it.
Yes. And sex. Yeah. That's another topic. I mean, let's get real. Well, so many parents are like, well, I don't want to talk to my kids about sex or contraceptives.
They're going to do it anyway.
Then they might have it.
Somebody's going to talk to them about it. And personally, as a parent, yes, those conversations make me sick, physically ill. However, I would rather the information come from me and open that line of communication with my kids. I mean, stop staying away from hard conversations.
Yeah, it's so true. So you learned that label, but how did you learn the label? Like, did the person on the team tell you about it, or did it become like
No,
an educational topic that the whole team had to learn about, or something like that?
we really got minimal to nothing in
Yeah.
regard to like trying to educate us around it. It was just like, okay, this person just kind of vanished and went somewhere. Um, and it was
Oh,
all very
okay.
confusing to all of us. And they were like, oh, so and so needed to go get treatment. But there really wasn't a lot about it. And she did actually, I went to this really tiny parochial school. So in the entire K through 8, there were 200 kids. So everybody knew everybody. Um, and so she did actually write a letter to the junior high for the teachers to share with us and kind of give
Oh,
us an
wow.
understanding of, what was going on. But even with that being said, it's not that they suddenly were like, oh, okay, we need to talk about this because it's a problem.
Yeah, of
And,
course not.
we're having experience with this. I mean, honestly, I didn't really have a health class at all in middle school.
Right.
So, uh,
I wish I could say I'm surprised by that, frankly. I mean,
same. I wish I was surprised.
and I say this like here we're in our 30s saying this,
Yeah.
but I still feel like it wouldn't really surprise me in 2022 to learn that certain things are off the table, depending on what part of the country you're in and how that curriculum
Definitely.
sways in lines with certain views for whatever the district is in for, which I won't get into
I was gonna say
that.
that was a very politically polite way to say that, Lindsay.
Why, thank you. I have a lot of experience in politics.
Oh my goodness.
AKA politics matter and they influence, our dollars, how
Everything.
they're spent, and how funding is allocated, which actually is another topic that I think Rachel can probably comment on.
Yes. I'll try to control myself in this conversation.
It's
No, it's okay.
okay.
We
We
like
don't we
rabbit
don't
holes.
want that. Yeah,
No,
we
we
don't
like
want
rabbit
you to
holes.
get It's okay. We're not seeking
So,
self-control in this podcast.
okay, good. So it's a whole lot of bullshit, to be
Yes,
completely
a whole
honest
bunch
with
of
you.
bullshit. Glad we
So,
got that
I
off the
mean,
table.
I admittedly am not as informed about the ins and outs of the insurance systems and the healthcare system as a whole, but I see the impact that it has on my clients and in individuals' ability to even access treatment. Um,
Mhm.
so mental health in general gets very minimal amounts of funding, but eating disorders in particular are like bottom of the totem pole for even so much as being talked about, being funded for research. There's just so little out there. Um, and so, in addition to that research and allocating resources for prevention and treatment, the ability for people to even seek treatment. Now, the fact that they even recognize that they have an eating disorder and are in a place where they want to receive treatment is huge. So, for them
Yeah.
to
Mm-hmm.
go to access treatment and it's either
Yes.
astronomically expensive because their insurance doesn't cover X, Y, or Z,
Yep.
or some insurance companies don't even cover all levels of care. Some insurance companies only pay for inpatient. And I'm like, because that makes sense. Let's not give them the treatment they need earlier. Let's wait for them to get so sick that they need an inpatient admission, because that's going to be cheaper for you to pay for than an intensive
Oh,
outpatient or partial
I just saw
hospitalization program.
as I'm hearing you talk about this, for those of you who are not listening to us on YouTube, Amber just had such a visceral reaction just now. And I just needed to like take pause and ask what just happened there.
So there's a common theme that I'm seeing, like probably in the last 2 years of my life, that as a society, we focus on fixing problems rather than preventing problems, which is incredibly frustrating to me from a health perspective, from like, and that's physical, mental, like all of the things. We would rather like throw duct tape on it, 10 years down the road instead of actually try to resolve the issue before it becomes problematic. So you saying that, like, it
Yeah.
was just another little block on my Jenga stack that I'm like, seriously? Like,
Yeah.
Yes.
Yep.
yeah.
And
Cause I
And
mean,
stuff.
this
even
is
when they get,
dangerous.
yeah.
Like,
Oh, yeah.
I know this is not like eating disorders. This is not something to play with. This is not something to like cast aside. It's not something to take lightly. This is something that impacts a huge part of our society, men, women, all of it. Like it doesn't leave people out. There's no one
Mm-hmm.
who's exempt from experiencing this. So it just bothers me, what you just said. So
As
that
it
was what you
should,
saw on my
Amber,
face,
as it
Lindsay.
should.
Yeah, no, it was a very visceral gut response I could see across
Yeah.
just your
And
body
even when they
language.
get into treatment and they have that resource, a lot of insurance companies require, like, they'll give you certain amounts of time. You have to call them and continue to argue for why this person needs ongoing treatment. And
Right.
so,
And
so
we
often,
have to do this all
yeah,
the time as clinicians.
exactly,
This is a part
exactly.
of our job, just so y'all know as listeners. This is our time that we don't get paid for this time. We spend hours on end advocating and fighting with insurance companies left and right, unpaid, trying to convince people why they need to provide care or coverage for care for our clients. I mean, this is a huge part of the behind the scenes aspect of the job that a lot of people do not hear about or know about.
Yeah, I had no idea that that was part of your role, until, you and I started talking about some of that stuff and just what goes
Oh,
into
yeah.
it, because that's intense. And I know, like, having a child who's gone through like some pretty intense medical procedures, I've spent a fair number of hours arguing with insurance companies and doctors, and like, to have to do that all of the time, good grief. Like, I appreciate y'all. I appreciate what you do, because, and y'all, like, as a collective medical, like, mental health society, like, thank you, because it's very frustrating to have those conversations.
Oh, it's exhausting. It's
Yeah.
exhausting. I'm sorry to have interrupted you, Rachel, on that, but I think that
Not
you are
at all.
bringing to light a really important topic that is relevant across all realms of mental health and the helping professions as a whole.
Absolutely. It's just so heartbreaking when I have a client who needs treatment, who wants treatment, who is actively trying, and I have to say, sorry, your insurance company has denied ongoing treatment at this level of care. And
Mhm.
it's just so defeating for everyone
Mm,
involved.
yeah.
Yep. And then when you take that to the next level, and we're looking at the ripple effect, because this is a
Exactly.
big part of when we think about the systemic change that we want to see unfold in our healthcare system or in various systems as a whole. When we think about systemic change, this is where I feel like it's so important for the decision makers, the lawmakers, to really take into account the ripple effect. Because when you're telling that adolescent that they cannot receive treatment, yet they have been brave and bold enough to share that they have this problem, of whatever kind of caliber, intensity, frequency, duration of an eating disorder, and then you are sending them home, and maybe their parent cannot afford to pay out of pocket.
Mhm.
Maybe they don't have health insurance either, or whatever the circumstances. In the state of Massachusetts, I honestly feel that the residents of Massachusetts are quite blessed and very lucky to have an amazing healthcare system, for those that cannot afford out of pocket. In the sense, if we're comparing to many other states in the
Sure.
United States. So, just insert that caveat. I think everything could always have a little room for improvement here, but just think about the psychological toll, though, that takes on the family and for the caregivers who can't provide help in the way that they want or the way that their child needs, and the ripple effect that has, especially when we think about the co occurring nature of eating disorders with depression or having
Mhm.
anxiety, and how even that linkage there with their caregiver, who will also likely have experienced or is actively experiencing their own mental health conditions.
For sure, for sure.
That's a
And it
lot. That's
feeds
a lot
into
to
this
unpack.
notion,
Yeah, sorry, Rachel, go
that they're
ahead.
not sick enough.
Mhm.
So when insurance companies come back and they're like, I don't think they need this level of care, the very fact that they were seeking care, such a barrier, especially with eating disorders, to help seeking behaviors, is this belief that they're not, quote, sick enough.
They're not sick
Like,
enough. Is that what you
I'm
said?
not sick enough. Yes, I don't need this treatment.
Well,
And so then
what's
for insurance
enough?
companies,
Yeah, what's
yeah,
enough for the
exactly,
Yeah.
insurance company? That's my question. What's enough?
exactly,
Cardiac
exactly. So
arrest?
yeah, for them to come back and just confirm essentially exactly what was preventing them from treatment in the first place is just,
Hmm. So what seems to be the, like, kind of the medical necessity, and I don't mean like you have to get into like the nitty gritty aspect of this, but if we think of like medical necessity criteria, generally speaking, in terms of what would make coverage valid, um, for just whatever kind of insurance company. I get it, they're all different. You're not speaking on behalf of any insurance company or whatever, but just from what you've seen, what are they looking for exactly to validate enough?
Right? So, amount of food intake. So if their behaviors are restriction, so how much are they eating? If they have other behaviors like binging or purging, how frequently is that happening? What's the intensity of those behaviors? What does the biometric data look like? Are they losing weight? Are their vital signs stable?
Mm.
Are their labs out of range?
Mm,
What
okay.
physical symptoms do they have? Are they cold all the time? Are they dizzy? Are they passing out? Um, so also that intrusive thought piece, right? Are their thoughts consumed by this eating disorder about food, about weight, about shape, about what am I going to have later? How am I going to get out of this social engagement that's linked to food? So they want to look at the thought piece, the physical piece, as well as like the emotions, so depression, anxiety. Are they having any suicidal ideation? What is the impact that it's having on their other psychosocial domains, which is always very significant as well. I
Of
think that gets
course.
overlooked because it's so much bigger than are they eating or are they not eating?
Yeah.
Right. And that's honestly, as I was listening to you say this, and obviously I have a little bit of behind the scenes information just on the professional level here, but just as I was hearing you say this, I'm thinking, isn't this interesting to hear? Because you work with this population all day, every day, whereas I do not. Because just of note, clinicians who are not specialized in eating disorders really shouldn't be
Yeah.
treating patients or clients with eating disorders. It is a very dangerous thing for someone to take on that kind of responsibility if you are not specialized in that treatment modality that's needed for that client. Because you're playing with fire. I mean, you're playing with
Mm.
fire, especially when you're talking about someone who's not eating or has a lot of, maybe their labs are totally off and things are not okay. You need to have some kind of medical oversight going on. So that's
Well,
just
and it's
another
an
FYI.
intervention team, right? Like you're talking about medical labs, you're talking about, so I mean, you're involving now a dietitian, you're involving, like it goes beyond one person helping, um,
Absolutely.
which, which from my perspective, like we get it, right? Because we know people, we've probably more or less experienced someone we know or love who has dealt with this. Like it takes more than one person to help someone overcome that hurdle and to work through it.
Hmm.
So the fact that an insurance company wouldn't be on board to help in that prevention, just it's baffling.
It
But
is.
well,
And so what I was thinking of, Rachel, when you were talking about elements of the medical necessity piece,
mm,
is while you didn't say it, I felt like in between the lines I was reading you say, they're also looking for like this piece of weight loss, kind of this
Yes.
hyperfixation of weight
mm,
loss. And so when I'm
Yes.
when I'm hearing what I'm hearing you say, and then what I'm reading in between the lines, which is where I get really annoyed because I have dealt with this end as a clinician. What happens to lovely individuals who are severely suffering with binge eating disorder? What happens
mm,
for the individuals whose focus is not on an extreme um, focus on like the weight loss piece or restriction piece, and it is a different type of eating disorder? And so
mm.
this is kind of where I really want to hear you share a bit more in educating our audience on the fact that there are more than just two types of eating disorders. And there are more than just three types of eating disorders. Can you tell us about the different types of eating disorders that exist, and help us understand why it's important for us to know that these things exist, especially insurance companies?
Absolutely. Absolutely. So, I think the media and everything that we see portrays one of two disorders, anorexia nervosa or bulimia nervosa.
Mm.
And there's this enormous misconception that it's a quote, teen girl disease,
A
right?
teen
That's your
girl disease.
demographic.
Yeah, right.
It's young women, they're trying to manipulate their appearance in a certain way. Men are not affected, children are not affected, older individuals are not affected. Like, and that very narrow mindset is another
Hmm.
barrier to folks receiving treatment because they feel very isolated. Or they're
Mm.
like, okay, well then this has to just be me because this isn't talked about.
Hmm.
Um, so other disorders. So I would not be surprised if a lot of your listeners have never even heard of binge eating disorder. It is brand new to the DSM-5. I understand there is an update now. So Lindsay, thank you for
Yes.
letting
Yeah.
me know about that.
Yeah. By the
Um,
way, that's new. Yeah. So the DSM, which is like our it's like our diagnostic Bible, so to speak, for mental health conditions. But that the DSM-5, the most recent, well, minus 2022, the most recent version was 2013. So they just came out with a revised version this year, 2022. So there's some new information hot off the press in terms of what we are allowed to issue as diagnoses to clients. And so there have been some elements of the DSM that were updated with as it pertains to eating disorders, which is
Mm.
like, thank goodness, finally, because maybe this can actually help move the mark a bit with the insurance companies to reconsider what medical necessity looks like, frankly. Um, Sorry, I'll go on a whole rant about that.
I feel that. I really do. Yes. So it's
Sorry.
like wonderful, we're making progress, but also look how many decades it took to recognize this.
It's
Yeah.
And so because
insanity.
it's still so new, a
Yep.
lot of people are still learning about it, including those who deem medical necessity, right?
And
So
therapist.
yes, exactly.
And
Side
therapists,
note.
many therapists don't even know that there's a
Yeah.
revised version of the DSM out. I mean, because it just came out. It's not like we got a whole alert from it. You know, it's not like they sent out this like
Yeah,
red
I didn't get
alarm
a text
alert.
message saying, "Hey, Rach, here's the new revision."
I was gonna say, is there like an email list you could get on?
I mean,
Probably.
I'm sure, but I'm sure it comes at the price of like $500 a year or something, just
Yeah,
knowing
Yeah.
probably.
our industry. But yeah, not so much. But I just there was I know I do want us to talk about the different types of disorders, but whenever you, I just want to skip back just a second ago when you mentioned it's a teen girls disease,
Mhm.
because I think also back when we were in grad school, I remember I did some work. Oh, it was you guys. It was with Dr. V. It was with
Oh,
Dr.
no
V.
way. Our
Yes,
friend Dr. V.
Dr. Villegas, one of our guest speakers. Yeah, so we had been doing some work for a school, and we were looking at the mental health conditions among student athletes, and it was fascinating
Mm.
because a big part of what we saw with even male athletes, because we don't really talk about males and eating disorders, but if you think about wrestling teams, for instance, um,
Mm-hmm.
that you will see eating disorders left and right in these kind
Mhm.
of sports, and unfortunately you just don't hear people talking about that, and it becomes one of those hush hush quiet social norms, and then these men go on to develop actually some pretty severe um, physical ailments as a result of the eating disorder.
Absolutely. It's so normalized in our society, this diet culture mentality. It's just so built into the air that we breathe that nobody
Hmm.
really blinks at it when they see it. And
Yeah.
so, because nobody sees it when it's starting, because it's seen as so normal, it has to escalate to a really severe degree before anyone acknowledges that it's a problem.
Yeah, before it's enough.
It's
Before it's enough.
absurd. Just I'm gonna try to stop rolling my eyes so loudly, but yes, this is absurd. Like just
Right. So,
okay. So moving
I
on.
want to. Yes, that's okay. That's all right. I mean, it's a topic that frankly this should make you mad. This should upset you. And hopefully people will get mad enough to do something about it. And whenever I say do something, I get it. Some people are like, "Well, I'm one person, Lindsay. What the hell do you want me to do?" Like,
Start talking to your kids. Start normalizing these conversations. Start
Yes.
making diet culture the unusual thing, not the usual thing. Like,
right. Just because you get blasted with diets and choose low fat, this, that, and the other, on social media and the news all day, every day, it doesn't mean that it's legitimate health information that you should be taking into account.
Yeah.
no,
And then
and
when
like
we,
there's a caveat, right? Obviously, I'm a health and wellness coach. I definitely prioritize eating healthy, but eating healthy is not restriction. It's not, oh my gosh, all this food is bad. You can never have this food again because it's bad. Food is neither bad nor good. Like in our house, I was trying to think of like how I talk to my kids because this stuff starts in adolescence. Like our relationship with food starts very, very early in life. And I talk to my kids about what different foods do in our bodies. You know, carrots help your eyes to be stronger. Oatmeal gives you good energy so that you can go play outside. Like we talk about foods, you know, chocolate is good for your heart, dark chocolate, that is.
All chocolate, Amber.
All chocolate is good for your brain. No, but these are conversations that start in the home, and that whether you have children or not, odds are at some point in every day you interact with another human. So maybe start by not picking apart the way you look or the way, you know, what your reflection in the mirror is. There's something that each of us can do, men, women, all of it,
Of
to help to
course.
start to break this social norm down and get rid of it for good.
Right. And even on that note, instead of greeting somebody and commenting on their appearance,
Mm-hmm.
why not greet somebody and, offer praise on their, I don't know, intelligence or
Yeah,
how
that'd be
they've
great.
been doing in life? Like, why does it have to be about, oh, you look great. Did you lose weight?
And that's such a
Yeah.
Oh,
compliment that we view if somebody asks
right.
us if we've lost weight, as if that's all we are meant to do in this world.
Well, in America it is. Didn't you know?
Yeah.
Yeah. No.
Okay, okay. Now I'll bring us back to our question from before.
Rabbit hole number 4.
Sorry, guys. This is how I operate. You just roll with it.
You're fine. We love you.
Don't apologize. These
Oh, well,
conversations are so important and not had enough.
they really are. But I want to bring us back to the different types of eating disorders
Mm-hmm.
because I do think it is important for us to increase some awareness about their existence. So, you mentioned that we've got, and I say there is the existence of anorexia, which is when people are choosing not to eat or restricting food, and really obsessively counting the calories and so forth. You've got bulimia, which is generally associated with the binging and purging of food. What else is there, Rachel?
Right. So I had started talking about binge eating disorder. So that is binge episodes without the presence of compensatory behaviors. And unfortunately, like the definition that we have for what classifies a binge, in our diagnostic manual is very vague. So again, it can be very hard for people to identify that they have this.
Mm-hmm.
And it's such an important topic with binge eating disorder. I feel it's one of the most stigmatized disorders. And what is interesting is
Yes.
the amount of people with this disorder outnumber anorexia and bulimia combined.
Oh, wow.
And they have about equal rates of men and women who are afflicted. Whereas with anorexia and bulimia, it's like women like 10 to 1, something like that.
Wow.
So many individuals are afflicted and no one's talking about it. And there's a lot of guilt, a lot of shame associated with this. I mean, with
Sure. I
all
mean,
eating disorders in general, but with
Mm.
binging in particular, there's a lot of
absolutely, because I think
stigmatization
too,
there.
when we look at American culture and at least other countries looking in, so much of what people talk about is, oh, Americans are so obese.
Mm.
Mm,
And we talk about that as if that is how culturally this is normal. This is how we are as
Mm.
a whole. And so why should an insurance company bat their eyelashes and give a shit when someone is, for all intents and purposes, appearing to be like, oh, you're average American. You're just
mhm.
obese. You just need to
Mm.
stop eating so much. What's the
Yep.
big
And
deal?
that oversimplifies it. The amount of difficulty that I face with primary care physicians who blame any and all ailments on weight,
Yep.
Mm.
even when it has
Huge
minimal
problem.
to nothing to do with it.
Say it
I
louder, girl.
went
Say it
in for,
louder.
yeah, I went in for strep once and my doctor's talking to me about my weight. I'm like, I literally just need you to give me some antibiotics for strep throat. I don't need to talk about my weight right
Yeah.
Yes.
Like
Well,
this is
actually,
not
you
part of the
you and me
discussion.
both. You and me both. I've absolutely had a doctor hyper focus on weight with me whenever I actually developed acid reflux, and that was
Mm.
actually shortly after I had Lyme disease. Well, I was hell bent and determined. If people are familiar with Lyme disease and even the treatment of Lyme disease, and doxycycline, which is the medication, the issue, and how it affects your body, developing GERD is not atypical after
Right.
getting prescribed a ton of doxy. And I was on that stuff for like a month. It was horrible. So
Mm.
now.
which is, yeah, I was overprescribed it. But anyway, I digress. The whole the whole point is that, the fact that the conversation of weight is what came up of, oh, Lindsay, you've put on about 15 pounds this year. Maybe that has something to do with it. It's like, why are we looking at that as the go-to? I understand that there has to be some rule outs, like we as clinicians do that for certain things. But
Right.
I agree that there seems to be a general focus on well, let's look at what you can control. Maybe you just need to lose some weight and then we'll
Mhm.
reassess.
That's a shame.
Absolutely.
It's
Yep.
That happens all too often, but perhaps we can help enlighten folks that there's more to life than that number on the scale, and there's other things at play. We put
Right.
far too much emphasis on that.
That is
We
absolutely
do.
correct. Can you
Yeah.
can you tell us what some of these other eating disorders are that you had
Yep.
that you work with on a daily basis and what you've seen?
Yep. So I think one that I think it's more rare to know of than not, it's called ARFID, which stands for Avoidant Restrictive Food Intake Disorder. So this is when there is a restriction of your energy intake, but it's not related to weight, shape, body image at all. So this could be an aversion to certain textures. It could be a fear of
Mm.
getting sick, a fear of choking.
Yep.
So they limit certain foods. And what usually happens is, say they had an experience where, okay, I choked on a green bean, right? So it would start, I'm avoiding green beans, but then it starts to generalize to foods that are similar to, and before you know it, they're eating three things: chicken nuggets, mashed potatoes, and maybe applesauce, right?
Hmm.
Um, and so I think that gets often underlooked. You see this a lot in younger children. So people
Hmm.
think eating
And
disorders, yeah,
and
they're not
children with
thinking little kids.
autism. Think about
Hmm.
Yes,
children with
autism.
autism, right? Because we really want to think about the sensory piece
Yes,
and the fact this is something that is so overlooked in the sense that there's a big connection there to take into consideration there because sensory wise, maybe certain foods and the textures don't feel good and I don't like them and I don't want to eat them. But then we're kind of maybe not acknowledging that this is entered eating disorder territory.
yes, yes. Because I think people get hung up on, well, yeah, they're eating. Okay, but do they have a variety? Are they eating mac and cheese for every meal of every day for,
Right. And are
months or
they
years
getting the
on end?
nutrients they need to
Yes,
fuel their body? Because food is fuel.
It is.
exactly. Food is your medicine. That's what we tell all of our clients. Food is medicine.
That's right. And then I'm thinking of another eating disorder. I'm gonna screw up the name of it. I always forget it because we don't talk about it. It doesn't come up much, and I think it's new to the DSM too.
Orthorexia,
Orthoxia,
Oh,
orthorexia, is that what it is? About
orthorexia.
the
Yes,
hyperfixation on like the healthy foods.
yes,
All right, well then, can you
yes.
tell us more about that one too, please?
I can. I can. So I am very delighted that this has been added to the revision because the board's been back and forth on this for a while. And so a lot of disordered eating starts with good intent, right?
mm.
Like I want to be quote unquote healthy, right? I want to be at a healthy weight. I'm going to cut out quote unquote bad foods. And by the way, our philosophy here at our treatment facility is all food is good food, all food is fuel. The components break down and provide your body with energy in the same way. So orthorexia is very much the same, right? It's like I want to do some clean eating. So they might start cutting out processed foods, for example, or eat like, we think, your most extreme, for example, raw vegan diets. And there are a lot of reasons that people make food choices such as that. But with
Mm.
orthorexia, it's an extreme. There's no flexibility with anything outside of this. They become very rigid with their exercise and fitness routines. And it really starts to limit them, both in their physical abilities, but also in their social life, in their relationships, in their work. So I think this flies under the radar because it's like, well, great, they're eating healthy, they're exercising.
Right.
Yes, yes, and I think a lot of people just equate those two things with the core definition of health, which isn't
Sure.
necessarily the case. Yeah.
Right, right. I can absolutely see that. I mean, if we think about, I'm just honestly, the first state that comes to mind is California. I mean, how can it not?
Yes,
It's
yes.
because, I
That's a
mean, we all literally,
generalization.
I mean, I'm just speaking
It's
facts
not a
here.
wrong one, but
You
yeah.
want your wheatgrass shots, and you want to have
Yeah.
your smoothies, and everything has to be organic, and it's got to be vegan, and you want to do this and that. And I'm not throwing shade on that
No,
lifestyle.
definitely not.
Yeah,
I say if you can afford that lifestyle, more
yeah,
power to you, but it's an extremely expensive lifestyle to live. But I agree, Rachel, is that when it becomes a fixation, and that is all, there's like almost like a level of hypervigilance associated with it as
yes.
well, where that's all you're thinking about and that's all you're willing to have. Or I kind of also am thinking like, does it also develop or manifest in like even a fear of contamination if it's not the right kind of food?
Mm,
It can. So different phobias, fear of contamination, OCD in general, we see
Yeah.
with a lot of our clients, and a lot of times it starts with OCD, and then OCD can morph and attach itself to food. So you see this escalation, and similar to with our grid, right? Things start to generalize and take on a life of their own. So it's not that if you like to eat certain foods and exercise that you have an eating disorder, but it's how rigid are you in these views, right? If
Hmm.
somebody offers you a cupcake at a birthday party and you have this really strong reaction, absolutely not. Like, I'm not putting that in my body, right? We think about how that impacts you on an emotional level, how it impacts you on that social level, right? There's definite um, maladaptive consequences.
well, it's that stress response, right? Like
Yeah,
it's not if you offer me a cupcake and I decline, that doesn't stress me out. Like that cupcake
yeah,
does not entice me because I don't like cake. I'm not like
I do.
I'm not a cake fan. Like so I would probably decline for a variety of reasons, but like if you offered me ice cream, then we can talk.
yeah,
But neither of those interactions cause me stress to either decline or accept because I have curated a healthier relationship with food than I've ever had in my entire life. But that does not mean that I'm not vigilant about what I put in my body because I do, like, I make certain choices for me because I know how my body reacts to certain foods and I know how I'm going to feel after I eat it. And I know innately I am better off without that cupcake because I'm not even going to enjoy it. But that's
mhm,
like, that is a different situation than I think what you're conveying about orthorexia.
yes. So many of the diagnoses in the DSM, one of the diagnostic criterion has to be causes, quote, clinically significant distress in life illness.
Mm.
Hmm. Right. And of course, that can perception is reality, I suppose.
Yeah,
It depends on who you're
Yeah,
asking.
absolutely.
It's so subjective, but unless there's
so
labs to back it
subjective.
up, right? I mean, unless there's hard proof to back it up. As I was as we've been talking about this, and actually earlier this week, the clinic where I work just had, ironically, timing wise, they just had a little presentation on diet culture and different eating
Mm.
disorders and stuff to bring everyone up to speed with the DSM changes and stuff like that. So um, one thing that I was thinking of even during that presentation, and even as we're speaking today, I'd be so curious to know, Rachel, if you've seen anyone who kind of fits the the bill here with this. But I'm thinking with this pandemic, with COVID, there have been in the last 2 years many, many people who have lost their sense of taste and smell
Mm, mhm.
to COVID. And to
Mm-hmm.
clarify, yes, maybe someone here listening, you've had COVID, you lost your sense of taste and smell for a few days or a couple weeks, but I think it's important to note that some people have lost their sense of taste and smell for months, for three,
Yeah.
6, 9, 12 plus months. And there are people that have now gone more than a year and a half without a sense of taste or smell.
Yeah.
And by the way, if you're one of those people, there are some phenomenal support groups on Facebook that are free and readily accessible for people to join. I highly recommend Googling it, looking it up. But anyway, my point is that these people, whenever they are eating, they experience a horrid taste in their mouth.
Mm.
Maybe it tastes or smells like chlorine or
Mm.
like sewage or something horrible, horrible, like just awful, awful, awful is how ammonia. There's been like different people to different reports around like a chemical type smell or something like that. Um, I'm wondering if you guys in the last 2 years have seen any shift or novel onset of eating disorders as it pertains to the desire of wanting to restrict foods or choosing not to eat at all as a result of the onset of the loss of taste and smell with COVID.
I think that is such a fascinating topic. And now I am very much wanting to go find more research on it. So I'm very curious in general
Thank
how
you. I'm very
the one,
curious
yeah,
too.
I was like,
Inquiring
oh
minds want to
man,
know.
what a great topic.
Why,
And I
thank
gotta tell you,
you.
it's not
I've been
really
a
something that I thought much about,
Yeah, so a lot of
surprisingly.
people haven't, and I've been thinking about this now for a long ass time, actually, long before this past week. I've been thinking about this for a while because I joined one of those support groups to better understand what a person was going through in the
Mm,
event that I ended up with a client that was navigating that. Because
yeah.
of course I'd hear people that were saying yes, they were losing their sense of taste and smell for a couple weeks or a week. But I thought, oh my gosh, how could I, as a clinician, how am I to support someone navigating this if they're now no longer eating? So through this, I've learned there's so many people who have given up food and are losing a lot of weight, and
Hmm.
they don't have the nutrients they need because it is so hard for them to eat. So I'm very interested and deeply curious about this topic and have been
Yeah,
wanting to dig into it to a bit. So I'm sorry I didn't
yeah.
give you a heads up that I was going to ask about it.
Oh no, that's no problem at all. Now I'm like, ooh, I gotta talk to my boss who's super into research and stuff. He would honestly be a riot on this podcast. And I'm really surprised that that hasn't come up so much in the work that I do. I can think of a few instances with individuals who had COVID and they lost their sense of taste, and they basically just used that to take advantage and eat, quote unquote, super healthy greens that don't necessarily taste that great,
Oh,
as an
okay.
attempt
Okay.
to
Kale.
manipulate their
It's
weight
kale,
and
isn't
food.
it?
Probably. So I have had that experience, but you bring up such an interesting point there, and I really do want to ask around and see what else I can dig up there.
Please
When I
do, and come back and tell us all about it.
Yes. And
I
I
would
also
love to.
think, Lindsay, you bring up another good point, right? So we're learning that there's more than just one or two forms of eating disorders. I think something on my mind is how do we better support the people around us to help make this less stigmatized, right? So, like, how do I show up for friends, family, loved ones in a way that is nurturing and kind and compassionate and empathetic, while
Mhm.
also like providing a safe space for them to seek help or to, make adjustments to their lifestyle that are healthier and better for their mental and emotional well-being?
Oh,
Right,
That's a big
right.
question.
I
It
want to
was.
answer
I'm
some of
like,
it too.
Yes, it's
jump
a good
in,
question
Lindsay.
for
What do
both
you?
of you. Yeah.
I
Yeah.
just, I instantly, I'm sorry. If we can share, that would be great. I would love to answer some of this.
Please.
Amber's laughing at me. Yeah, because I was just thinking, like, the one thing that I wish family members would seriously cut the shit on whenever it comes to family holidays. Even whenever I'm thinking, let's see, summertime, right? Here it is. It's summertime. We're thinking of like the nice sunshine, cookouts, eating lots of food and all the things and having a good time. But can the family members just cut the shit with making the small nitpicky remarks, the judgmental passive ass statements about, "Oh, you're having a second plate?
Hmm.
Oh, wow, you must be really hungry today. Look at how much you just ate. God, you ate all that?" So I would just like to do a call to action to please shut the fuck up. I mean, nobody needs
Yes,
to hear
Look,
that.
and
that pisses me off to no end.
the other side of that, like coming from personal experience here, let's just not comment on what people are eating in general in those
Yeah.
Yes.
circumstances, because like
Yes.
I have been on the other end of that. That's like, oh, you're choosing a salad. Why don't you eat this
Hmm.
burger? Like, why don't you eat this instead? Oh, you must be
Yep.
too good to eat this other food. I'm like, no, like it has nothing to do.
Right.
I'm eating the food that I enjoy. I'm eating the food that I want. Like, let's just
Yeah.
stop commenting on our family members' food choices, perhaps. I think.
Or friends, whatever. I mean,
yes, friends,
clearly I'm
family.
getting a little feisty over here on this because
You
I'm
are
just
so
Say it
feisty.
again for the people in the back, right?
hey, listen, I
Stop
really am
talking
because
about food and
for
body
real,
shapes.
I've
Yeah.
had people comment on like how much I eat. As this has been a huge part of my norm, by the way. I've never had a reason to bring it up because frankly, it's never really come up in conversation. I guess it's just been one of my normal things, right? One of my toxic norms. But you know, I grew up with my mom being a chef, so I was around food my whole
Mm,
life.
yeah.
And you know, eating was eating a lot of food too was like really normal. And you know, fortunately, I will say I've been blessed with some high metabolism, and but people would constantly question or be like, "Oh my gosh, I can't believe how much food you're eating," or "Wow, you know, you're gonna gain a lot of weight," like you know, just comments like
Mind your
that,
own
and
business.
they're so
Yeah.
unnecessary. But on top of that, I think about I had a client one time with binge eating disorder, and that's not why they were seeing me for treatment, but that's okay. And you know, one thing we would definitely do some safety planning around holidays, Thanksgiving,
Mm,
Christmas, birthdays, but
Yeah.
especially Thanksgiving is a very triggering holiday for so many people
yep.
because at least in the United States that holiday is so centered around food consumption as a way to bring people together. Um, and I think it's important to remember not to put pressure on people or expectations of what they should or should not be eating, how
Mm-hmm.
much they should or should not be eating, and then thinking of healthy coping skills to help them navigate that. I typically encourage people like always keep a book or a fidget or
Mm-hmm.
AirPods nearby so that you can listen to a song, even if it's in the bathroom, listen to a song for 2 minutes to help
Mhm.
kind of as like a as a distress tolerance skill, essentially. Just to kind of keep yourself grounded in these moments where you really don't want to be around these people who are frankly quite triggering for your food disorder, whether it be disordered eating or eating disorder.
Those are good tips, Lindsay. And it's even if it's not in dealing with a disordered eating or eating disorder, like sometimes family stuff is just triggering to anxiety and to nervousness and to all different areas. So I think those are useful tips for all of it. And I mean, personally, like when I find myself in those situations, I sometimes excuse myself for a walk, like
Yeah.
Yeah,
just
take
take
space.
myself out, get a little bit of fresh air and remove myself. Because while we do as a society make most of our holidays about food, like that doesn't have to be the stressor. It doesn't have to be like the thing that we focus in on, even though that is the
Mhm.
norm.
It is.
Exactly.
So now, Rachel, I'm sorry that I had to jump in on your question, but it was
She dove right in, man. She went right for the
I,
kill.
I did. I got feisty on that one, y'all.
No,
Sorry.
I love it. I love it. And I think you had such excellent things to share with that. Um, so
Well,
it
yeah.
is a
Now,
big
what was the
question. So I'm trying to
question?
see how
No.
to focus, trying to figure out how to focus my answer. But yeah, I think American culture, you know, Thanksgiving, Christmas especially, but pretty much any social gathering is just
Yeah.
around food.
Hmm.
And there's this expectation in that regard. Um, and so if you're trying to support someone, you know, the anxiety and the depression and the family stressors and the eating disorders, you know, forgive me, but they feed into each other. Um, and so individuals who have to go to something around food and if they're struggling with disordered eating or an eating disorder, that's going to be anxiety provoking in and of itself, let
Yep.
alone having family, friends, random acquaintances commenting on what they're eating.
Yeah.
So, I mean, the best advice I can give to loved ones of people struggling is do not ask them about their food plate. Do not, unless they specifically ask you to ask those questions, right?
Right.
Do a general check in. Like, how are you feeling right now? What do you need from me right now? What would be helpful? How can I support you? As opposed to asking very specific food questions that
Yeah.
usually just shut people down.
Yeah.
Um, and having those distress tolerance skills, having an exit strategy, having like a hand signal or something to an ally of yours there. I always say, have a buddy, you know, buddy
Mm-hmm.
system, have somebody
Yes.
there. If you're
That is
feeling too uncomfortable to redirect the
great tip.
conversation, have somebody else there who can.
Yeah.
Right. Have somebody else who can redirect or be like, dude, you're being a moron right now. Like, stop talking. You don't know what you're
Right.
saying.
Someone that can pick
Um,
up on the body cues
yeah,
and sense that that
exactly.
person's feeling uncomfortable. Have an ally. I love that suggestion, and it's a wonderful one. Because truly, I think we could all use an ally in those kind of events, because holidays and things like that can be stressful in of itself. So, um,
Absolutely. And I would say, like, from my perspective, like, I would be, I don't know if honored is the right word, but like if someone asked me to be their ally in that situation or asked me to be their buddy in that situation, like 100%, I'm in it to help you. Like, you need an exit strategy. You need someone to change the course of the conversation. You need someone to step in and tell someone to back the hell off. Like, cool, cool. I'm your girl. Let me know. But like, we're going to have to speak up, and we're going to have to get comfortable saying like, I need
yeah,
help, or I need you to be here for me. And as a collective society, we need to be ready to step in and say, yep, I got your back,
yeah.
instead of making people feel less than because they're asking for help and they're being honest.
Mhm.
Yeah. It's so painful. I just felt that so hardcore in my soul there, because I feel that when you see someone who's genuinely struggling with this, and Rachel, the fact that this is your specialized population, like, mad respect to you, seriously, because
For sure.
it is a hard, and I mean, I get it. We all have our own little niche or whatever, but it's a very tough population to work with, and it is so heartbreaking. And something that I just want to actually draw a connection to for our listeners as I'm saying this, because I feel similarly when I work with clients that suffer with substance use disorders,
Mm.
um, is that in terms of eating disorders, it is very similar to how substance use disorders operate. And I think that
Yes,
that's something that, as a collective, we need to keep in mind, that this is also a form of an addiction.
Mm-hmm.
it
And
is.
ad- yes, I mean, addiction it looks different for different people in different ways. And it can be to a substance such as food or alcohol or drugs or gambling or sex or whatever. But in terms of the clinical approach, we're still treating it from an addiction standpoint.
Yes. And I would love to comment on that if I could.
Please
Um,
do.
I know I had mentioned at the start, we learned about eating disorders and substance use disorders together. And yes, it kind of seems like we're brushing off both and not diving deep in, but there's a reason that we learn about those together. And not only just in their treatment modalities, but both are highly genetic disorders. And
Mm.
the dopaminergic system in your brain is what gets activated with substance use. And it's the same exact spot that gets lit up for eating disorders. And
Tell us what that part of the brain does, please, for those that are
so
not
that
as
is
familiar.
your right. So your dopamine system, right? Those are your feel good chemicals, right? So it's very
Mm,
much this like pleasure, instant gratification. You see it a lot with impulsivity as well.
our pleasure
So it's
principle.
that, yeah, yeah, exactly. Yeah. So, oh man, I took like a neuropsych course, and my professor would be sad that I don't remember more about that right now.
That's okay. Hey,
um,
I wasn't trying to put you on the spot, but just the basics of making sure that our audience understands
yep,
what you're
Yeah.
tying together here is saying
absolutely.
both substance use disorders and eating disorders are both connected to that reward system or that pleasure
Yes,
principle in our brain. We don't have to get
yes.
into the really crazy specifics. That's fine.
Yeah. So, and in recent times, substance use disorders, they've gotten more attention, which is phenomenal. That they're starting to be
Mm-hmm.
talked about more. There's starting to be more resources laid out for people, and so sometimes people can conceptualize substance use disorders better than eating disorders. So when I do family sessions, for example, a lot of the time I hear, well, why can't they just eat? Like I don't understand. Like that they need food, they need to eat. Why aren't they eating?
Right.
And so sometimes if I can explain it from more of a substance abuse lens, it
Yeah.
clicks a little more that it is an
Hmm.
addictive behavior, that they're not choosing to do this, that it's just this vicious cycle that perpetuates itself.
Yeah.
Yeah.
Um, so yeah, that can be a helpful tool as well for some family members.
I think that's super
Yeah.
helpful. And like what I'm hearing from both of you is just like be a listener, not a
Yes,
fixer. right? Just be willing to be open and hear what someone is sharing with you without judgment, and stop commenting on food choices and body image and like all the things, because what matters about a person is their inner light, not what you can see on the surface. And while I will always advocate for taking care of the body you're in, that does not mean shrinking the body you're in.
Right. 100%. I mean,
Like that's not the bottom line. Like it can be a byproduct. Like, yes, I've lost 101 pounds. That is important to me because I'm giving myself a longer life. I'm giving myself energy to hang out with my kids. I'm giving myself the ability to have less painful days and to get up off the floor by myself. But my validation as a human is not tied to that weight loss in any way, shape, or form. And I think that's like, we need to do a better job as talking. And I know as women, like it's very normal to sit down at a table and hear someone say, oh my gosh, my muffin top. Oh my gosh, this. Oh, like, stop. Everybody has roles when they sit down. Like it is just your human body was meant to bend and roll and flex and do the things. So the hyperfixation on that. Yeah. Like thick thighs save lives. Isn't that what they say? I know it saved my cell phone a couple of times.
I like that. I like that. Thick thighs save lives. I like that a lot. I like that one a lot.
You're welcome. I mean, I didn't come up with it.
I think there's a takeaway though, in understanding that no, there is no one look associated with an eating disorder.
True.
And just in general, I'm wondering if Rachel, if there's anything else that you'd like to add on that, or just even in the overarching theme of this topic as a whole.
Yes, absolutely. So people get very caught up in, well, I don't look like I have an eating disorder, right? That is the craziest sentence ever. There is no one look to an eating disorder. Even if you have an identical diagnosis, you can have 10 people diagnosed with anorexia restriction type, and they are going to manifest in 10 different ways. You cannot just assume that folks have an eating disorder based off of what they look like. So that I think is so important to know, that you can't just look at someone and be like, oh, anorexia or oh, binge eating disorder. And that's just so harmful in terms of the stigmatization and the, feeling that you're either not sick enough or you're not validated, right? Because a little bit frustrates me, the diagnosis of atypical anorexia that doesn't have as much of a focus on the amount of weight that needs to be lost, because again, I feel like it stigmatizes that person, and that, so you have an eating disorder in general, that's going to isolate you, but now you have what's an atypical eating disorder, so let's isolate you further, right? So I mean, yes, weight is important. It's important to track, important to monitor, but that is not even remotely close to the only thing that we hear about.
Absolutely. Here for that.
Yeah, absolutely. I mean, hands down. I mean, it's just there's more to us than the
our gravitational pull,
our body, or
gravitational pull.
I mean, our body looks. I mean, that's hands down.
There's this quote that I love that we actually used to have above the scale at our treatment center, and it says, all the scale measures is your numerical relationship with gravity. That's it. You're going to weigh different on the moon, on Mars, or whatever. This number has nothing to do with anything except gravity and the Earth's pull.
Yeah.
Yes. And honestly, just as you were even mentioning that about the scale, just one last little tidbit of an area where I feel like we could use some improvement, where maybe our primary care physicians could help out, is maybe just automatically having people step on the scale where they're not necessarily facing the scale is another thing.
Yes. Not everyone wants to see their weight. They don't always get the opportunity or are comfortable saying, hey, I need blind weights and this is why.
Yep.
And what kills me further is even when they say that, it ends up on their paperwork anyway.
Yes. Yep. Yeah.
I will say you are 100% correct. And I have noticed my primary care physician is definitely like forward thinking in this, because for the last 3 years when we go in, it's, do you want to know the number? And they have the information like facing away from the scale. So it's not like, I don't have to make any decisions until they say, hey, do you want this information or no? And I think that's a huge part of taking the stress and anxiety away from this, because I don't get to see the rest of the chart information. Like, why do I need to be bombarded with that? like
That is
right up front at the
amazing.
start of the appointment. It's incredible. And more
Good
doctors'
on
offices
that
should do
primary
that.
care.
Yeah.
That just made me think one more public service announcement. You can decline to be weighed. I think
Yes,
we
you
forget
can.
that. We forget that when we're in this, sort of quote unquote like power differential, like I'm the patient, this is the doctor, and they're telling me what to do. You can decline, no questions asked. And I think
So
we forget about that.
fun fact, when I was pregnant with my first child, I had a doctor tell me I was obese and that I was harming my child because of how heavy I was. And after that point, I refused to see that doctor anymore. And I declined all future weigh-ins and just told them that like I would provide them the information by email if they truly needed it, but like that was not going to be a part of my report. And then I went into labor and that doctor was on call, and I may or may not have refused to go into the hospital until he was no longer on call.
Good for you. Like snaps for you. That's awesome.
Wow. Yeah,
And this is when Hazel came into the world, Lindsay. So I think I might have manifested some of her
fire
her shenanigans.
That's why she's so damn fiery. That girl, I swear, y'all, Amber's daughter is going to change the world. She is a straight fireball, that one. But it makes sense. You freaking birthed her under fiery conditions.
Under very fiery conditions. Like that was my bad. But and I'm not advocating for anybody to like keep themselves from the hospital while in active labor. Like not a good idea. Probably not one of my smarter choices, but real talk, it's what I did because that man was coming nowhere near me.
Yeah.
Wow. I mean, so yes, let's hear it for trauma-informed approaches, guys.
For sure. No, this has been such an enlightening conversation, Rachel. I appreciate you sharing this with us. I definitely came away with new information and new tools in my toolbox to be able to help folks that I work with in my client space and also in my friends and family unit as well. So thank you.
You're so welcome. And Lindsay, I can send you resources for treatment options. So, you can link it to wherever you post this if people are interested. There are plenty of resources available to you. Just make that first click, make that first call, schedule an evaluation. Even if you choose to do nothing with that information, at least you have it in the book.
Yeah,
so
absolutely.
I'm happy to send that over.
We can definitely include some links in the show notes for today's episode. And then you guys can just kind of scroll on through and pick what looks like as whatever's good for you or your family. I'm so glad that you could join us today and I know that honestly, we only just scratched the surface today.
We did.
But I'm so glad that we were able to at least talk about some of this stuff, get the conversation out there. I think this has been a wonderful topic for Mental Health Awareness Month. And truly, thank you so much. And please keep us posted on any research that your boss might come across. We want to hear about it.
I got you. Thank you so much for having me.
Thanks, Rachel.
All right. Bye, guys. See you next Tuesday.
Bye.
And we all sing, everything is gonna be just fine. It's gonna fall into place. The sun is gonna set on your terrible day.